Hello and welcome everyone to the MedEd podcast. I'm your host, Bill Fralick, and joining me for this special episode today is Bryan King. Bryan is a respiratory therapist that has got many years of experience in the neonatal world. So, Bryan, thank you for joining us today and welcome.
Thank you. It's good to be here. How are you?
I'm doing great, thank you. Thank you much. So, as clinicians, we always have a lot to talk about, whether it's management of ventilation or different types of modalities.
Yeah.
So, with your time in the respiratory world, you've probably seen a lot of different changes, whether it's different types of modes or different types of devices that we're using to manage patients. Can you kind of walk us through first, before we talk about that, a little bit on your background? Kind of where you've worked, some of the different
Yeah.
roles you've had, just to kind of give our listeners an idea of what kind of experiences and insight that you could provide.
Absolutely. Yeah. So I grew up in the mountains of North Carolina. I grew up in a farming community up there. If you've ever seen the Andy Griffith Show, I grew up in
Yeah.
Mount Airy, which is Mayberry from the Andy Griffith Show.
Yep.
Um, Eventually became a respiratory therapist in a non-direct route. I was actually managing an American Eagle Outfitters and um, had actually gotten into X-ray tech school.
Oh.
But I was following around an X-ray tech on the Friday before school started, which was
Hmm.
supposed to start on Monday because they had an observation that was required. And I go and I think to myself, this doesn't look like the most exciting thing I've ever seen. It looks kind of boring. As a matter of fact, I need something else. So I actually called my wife and said, what do you think I should do? This doesn't look like something I would really be interested in. She was, "Well, call the community college, see if they have anything else." And so I did, and they had one opening in respiratory therapy, and I said, "I'll take it. What's that?" And that's how I became a respiratory therapist. I did not put a ton of thought into it, but I
Hmm.
fit into this career like a round peg in a round hole.
Oh.
I have loved every second of my career. I was fortunate. We had to do an observation as part of attending respiratory school as well, and
Hmm.
I went to the neonatal intensive care unit and was
Oh.
enthralled. I loved it and I immediately knew I wanted to take care of babies and children for the rest of my career. And I've been fortunate enough to do that.
Yeah, that's awesome, and I find it really interesting to hear from friends and colleagues that work as respiratory therapists how they got into the field, because it's not like nursing or being a physician, that they're very well highlighted, the
Yeah.
schools and the programs. So, back when I got into it in the late 90s, it wasn't the most popular profession.
Yeah.
I was a medic in the Air Force and did some of those same things we do as respiratory therapists, and I
Yeah.
really enjoyed that, found it super interesting. So when I got out, I looked into the respiratory career field. But yeah, I always find it super interesting how their path led them to that.
Yeah.
And you're just a perfect example of how career choices could happen in a moment's notice, and
Yeah.
sometimes you kind of plan it out a little bit more. But no, I'm happy to hear that you've enjoyed it so much, like myself. It's a very rewarding field and so much interesting stuff to do as respiratory therapists and learn as RTs as well.
Yeah. And one interesting thing, I've been fortunate enough to work at a couple of major medical centers, Forsyth Medical Center and Wake Forest University in Winston-Salem, North Carolina. And they were great facilities, and I've
Yep.
learned so much at those places. And then I've been able to be a consultant for Draeger. I've been able to be an educator for Bunnell. This has been a career path for me that has been intensely rewarding. I've said, and I think that this is probably true. Had I known at the age of 20 how much I would enjoy medicine, I would probably have made a mistake and gone to medical school. But I
Yeah.
would not have enjoyed being a physician, and I don't think I would have enjoyed the career I've had and been fortunate to have as a respiratory therapist. I
Yep.
would never trade the career I've been able to have for another profession. I've been very fortunate. This is
That's
my
that.
my ode to respiratory care as a profession. It's been great for me.
Yeah, that's awesome to hear, and I would echo those sentiments from my perspective in my career. Um, I've worked at some big medical facilities, learned a lot, came into the medical device industry as well too. Love that as well. So I've
Yeah.
been very fortunate, as you have, to really find those roles that you just kind of, like you said, round hole, round peg, fits
Yeah.
great. And I've been fortunate enough to have my team, my colleagues that I work with, just phenomenally talented individuals as well too. So yeah, definitely very much aligned with what you said. Is just fantastic career field,
Yeah.
fantastic. So now that we've kind of talked a little bit about kind of background, where you've been since you joined the profession, as I mentioned earlier, you've probably seen a lot of different changes, whether it's a certain mode that we use or a certain device that, is kind of the hot thing of the moment.
Yeah.
So kind of take us through kind of what you've seen in that evolution in the neonatal world, from, it could be from a ventilation perspective, whatever you kind of want to discuss there. But yeah, kind of things that you've seen that have really, you feel maybe improved patient care, uh, from your perspective there.
Yeah, that's a great question. One of the things I'm actually playing around with writing a book right now about my profession, and really what it's about is being teaching physicians as a non-physician, right? So
Mhm.
it like I said earlier, it's been intensely rewarding, but it's also a fraught situation where
Yep.
you're not a physician, but you're in a room full of them. And so you've got to be able to impart knowledge in a way that's it's accessible for them and in a way that meets them where they are. They're not necessarily device people. As respiratory therapists, we're device people.
Right.
They're not necessarily device people. So you've got to stick to the domains that are in their comfort level.
Yep.
One of the things that I always mentioned was I would stick to ventilation theory, disease process, mathematics, and physics. If you're in
Mhm.
those domains, those are things that are easily accessible for the physician group. It's their
Agreed.
comfort level. All
Yep.
right, so that's how I would teach, and that formed like the structural underpinnings of my teaching style and strategy. But as far as what I was teaching, well, that has changed over the years, and the way I talk about it is we've had revolutions in
Mhm.
neonatal ventilation. So I started in 2000. Or that's at the very tail end of the um, the early surfactant and antenatal steroid revolution in the
Okay.
neonatal realm.
Mhm.
What I mean by that is that's when people were already doing those things. Babies were getting more moms were getting antenatal steroids and babies were getting surfactant at delivery, but it really started to come more into vogue. Well, that did a couple of things for us. It changed the compliance of the baby at the bedside. So you go to
Yep.
a delivery in 1990, that baby, same gestational age, is going to have a worse compliance than the baby that hits the bed in 2005. Right.
Yep.
So the size hasn't necessarily changed. Or let's say it's a 28 week, or the size hasn't changed, but that kid's compliance has changed. Well, what that's done for us is it's allowed us, or maybe the word is forced us to work with a smaller and smaller patient population.
Yeah.
24 and 25 weekers, then 23 weekers, and now 22 weekers.
Right.
That to me, the antenatal steroid and surfactant revolution are the things that have had the biggest influence on my actual career.
Okay.
As far as the things that I have actually physically taught, or I guess mentally taught, the things that I've taught have been volume targeted ventilation and high frequency ventilation,
Yep.
and I treat those as revolutions as well because
Hmm.
those have really changed the way we've practiced.
Now with those two, the high frequency and volume guarantee, have you seen those modalities improve the patients? Because I can think when I came in, again, I was more of an adult therapist, but you hear a lot about the more we're utilizing pressure
Yeah.
ventilation back in the late '90s, early 2000s. So, are you seeing patients do better with like a volume guaranteed or a high frequency?
Yeah, yes is going to be the answer, but there are always caveats. Some of it's going to be the way you approach those modalities.
Hmm.
Some of it's going to be the child in front of you. The fact that when I started my career, we were basically treating 24 to 28 weekers. That was our patient population.
Mhm.
Now it's 22 to 26 weekers. For the most part, the 26 to 28
Uh,
weekers are just better. That's the
yep.
neonatal steroids and surfactant.
Okay.
But we're treating smaller and smaller patients. And so the issue we're running into is the strategies that we had that we've got tons of research on for 24 to 28 weekers
Mhm.
may not extrapolate down to the smallest nanopreemie population, those kids
Gotcha.
below, say, 600 grams.
Right.
And so we're in this situation where we're still trying to figure out what a best practice is. And there's never going to be a grand unified theory of ventilation. That's never going to exist. And
Very
it's
true.
okay.
Yep.
You can have uh, a disparate strategies at different facilities as long as you're really good at them. And
Yep.
I really used to say this to folks. I'd traveled all over North America teaching neonatologists. I don't care where you start. I really
Yep.
don't.
Yep.
I would try to get a feel for what your overall strategy was when I would
Mhm.
go. I would ask, do you guys do bubble CPAP? Do you do volume targeted ventilation? Do you do early oscillator, early jet? And I didn't necessarily care what they told me
Yep.
because at least they had a strategy, and that's a good
Correct.
starting point. What
Absolutely.
I would try to impart on to them was this is your strategy. It's a perfectly reasonable strategy. What do you do if the child responds poorly? You've got to have somewhere to go. And so I've always been a big proponent of having multiple tools in your toolkit or not being a one trick pony,
Definitely.
right? And I feel like that in my career has been the thing that I've been most successful at teaching is you've got your strategy and it's a perfectly reasonable strategy. Here's the point at which you should deviate from it.
Yep. Now, do you think it's challenging sometimes to identify that threshold where you need to adapt the strategy, even if you have a second one or you have three solid strategies? Can that be challenging at times to identify that threshold where it's like, okay, this isn't working, we need to adapt it? Is it a time thing? Is it, obviously you got to assess your patient, but do you find that one of the challenges to implementing that strategy B or strategy C at that time?
Yeah, that's a really good question. One of the things that I had happen not terribly long ago, I was lecturing at a hospital in Toronto, and
Mhm.
one of the therapists there said, "Well, I could ask you, I could call you tomorrow and ask you about a specific patient, and I could call you 5 days later and ask you about that same patient, and you give me a different answer." And I said,
Yep.
"You should be excited by that." And he said, "Why would that be true?" I said, "Because that child has changed. It's been
Yeah.
5 days.
Yep.
If you're 5 days old, so if you're on day one."
Mhm.
And you're 5 times that age, when I'm 5 times my age now, I'm gonna be dead. But that baby is 5 days older, but he's 5
Yep.
times as old as he was when you called me that first time.
Right.
Strategy needs to change. You've gotta be able
Absolutely.
to change because he's not the same child. And so we need to be able to explain to folks why they would change. And it
Yep.
usually has to do for me with I get to choose my settings. I get to
Yep.
choose my modality, right? So I get to choose those things. I'm imposing them on the patient.
Yep.
If I choose a rate or I choose a nighttime, that's mine. That baby didn't choose that. That's
Right.
mine. I
Yep.
imposed it on that baby. So the thing I can't control is response. So I
True.
can control the things I give the child, but I can't control what the child's response to it. So I need to have the humility to be able to recognize when I'm going in the wrong direction
Yep.
and change.
Yeah.
And so that's the way I've
Absolutely.
always approached it and tried to teach it.
Yeah. And I think from my perspective, as you get more experience working with those types of patients and more comfortable with, adapting your strategy, I think that comes with experience as well too.
Yeah.
But also, experts like yourself that be able to kind of present on that, like have that second strategy and here's things you should look out for to ensure that you change it at the appropriate time as well, so you're not doing it too early or too late.
Yeah.
Um, and that, as clinicians, that's what we do. We get more experience, we get more knowledge on that, and then again, have experts like yourself be able to have like that resource, like, oh, that's right, Brian presented on this piece here. Having that second strategy, I think for especially for newer clinicians, that is so important nowadays. because our patients are getting sicker and sicker,
Yeah.
and having again those resources, whether it's a video lecture that you did or recalling a lecture that they attended live, that goes a long way to just like, aha, they have that aha moment where that's right. They talked about this. I can see that patient, we're in time for a change, and we have that second strategy ready to go. So, yeah, that's so important, and so glad to see someone like yourself to be presenting and talking about that type of stuff, because I think that gets lost sometimes because we're so focused on what settings they're on, what ventilator they're on, and again, thinking about that additional strategy, I think can go a long way to really improving your patients.
Yeah.
Well, good. So talking about patients and the team that's in the ICU, you know, probably in the last 10, 15 years, at least when I was bedside, you heard a lot of talk about those collaborative teams where you have
Yeah.
physicians, RTs, nurses, dietary, all those different teams coming together for, their rounds, whatnot. Um, so what have you kind of noticed in your career? Has that team evolved? Is there still room for, you know, more evolution or more collaboration with those teams? Kind of, yeah, give us your perspective on those cross collaborative teams in the hospital.
Yeah, I've been fortunate in my career to also have covered Canada.
Oh,
And one of the things that I noticed in Canada is the respiratory therapists were considered an absolutely integral part of the team. I
hmm,
see that in the States,
yep.
but it was universal in Canada. And
Oh,
so
wow.
one of the things that I think is incumbent upon all of us, we got to show up.
Yep,
This this is it's important. There are, it's, at least in the areas that I've worked, there are babies and children attached to the ends of these devices.
yep,
We've got to show up. We've got to be prepared. We've got to be comfortable sharing information.
yep.
And that was a hard thing for me to learn. The the white coat fear was
Mm,
something I had to get over, right?
absolutely.
And
Yep.
and you know where I learned that lesson first? I was in rounds one day and I pulled a punch. I had a physician ask a question to what I thought we should do
Hmm.
with a specific child on the ventilator. And it was so funny. I gave her the answer I thought she wanted
Okay.
and did not go as far as probably I should have. Definitely I should have. And she knew. And she took me aside afterwards and said, "If you're not going to tell me what you actually think, you're
Hmm.
of no use to me."
Wow.
And that's it's stern,
Yep.
but it's true. And
Yep.
we have a knowledge base as respiratory therapists that we can bring to the table,
Definitely.
and you've got to be comfortable sharing that information, and stick to the domains, right? Stick
Yep.
to the ventilation theory, disease process, mathematics, physics. Stick to those four domains when you're describing this information, and then you don't have to always be right, right? You're
Yep.
What you're doing is you're giving them options and opportunities
Yeah.
that
Do you
maybe
think
they've
that's
not
part of the
thought about.
fear? Do you think that's part of the fear speaking up sometimes? You don't want to be wrong, or you're not going to give the correct answer that doctor may agree with? Do you think that sometimes holds some therapists back?
Sure, it does, but if you can live in those 4 domains, you've at least got the structural underpinnings for what you're proposing, right?
Agreed. Yep.
And so thinking about it that way, you don't have to always be right. You're just offering another set of options. And
Absolutely.
then, all right, so I'll say this as someone who can be opinionated and is very comfortable sharing with the physician groups. I always thought it was incumbent upon me if I was wrong, and
Hmm.
and nobody gets to just be right.
Yep.
When I was wrong, I would own that and I would do it in public. I
Yep.
would go into the group and go, "Hey guys, looks like my strategy was incorrect. Does anyone
Hmm.
else have any strategies that we could try?" And I think
Yep.
that's important. Be
Yep.
humble enough to own being wrong. And
Yep.
you know,
Absolutely.
I've been
Yeah,
wrong
because
plenty of times.
yeah, I mean, but just thinking about the impact we can have on those discussions during those team meetings like that. I mean,
Yeah.
you talk about the ventilator, how it's impacting how the patient did the night before, give your, recommendation for any changes, whether the patient's waiting for weaning. that can have major impact on how that patient does, whether the patient gets off the ventilator. So I agree. It's really up to us as therapists. If you're in a culture that doesn't necessarily promote RTs, part of
Yeah.
that team to get yourself involved with it. Like you said, speak up. Sometimes if even if I didn't have anything to contribute, I would show up just to learn about other patients. Because if they
Yeah.
start to deteriorate, you want to know what's going on with that patient and
Yeah.
not have to do it in a very chaotic, emergent environment.
Yeah.
So knowing about your patients you're covering is important, even if they're not necessarily um, on the ventilator or getting some kind of direct care from you. And then I think the more they see you in these meetings, the more they're open to asking for your opinion and your recommendation. So yeah, I think as RTs we should really empower ourselves to become part of that collaborative team.
Yeah, one of the things I've always said is you get the level of autonomy and respect you deserve. You have to
Yep.
go carve it out for yourself, right? But you get the autonomy and respect you deserve, and so go carve it.
Yep. Absolutely. Completely agree. Great discussion so far. I'm going to transition to kind of maybe some forward thinking. So,
Okay.
what do you see? What would you like to see moving forward with clinicians, RTs that work that NICU area in the future? Is any type of different approaches as far as modes or protocols or whatever you might think might be important that we really look out for and address as RTs in the future?
So I feel pretty comfortable saying this. And I try not to deal in absolutes, but I
Yep.
feel pretty comfortable saying this for our babies below 600 grams, which I call nano preemies. For
Hmm.
that patient population, our enemy is hyperexpansion.
Ah.
It's the thing that's hardest to treat, and it's the
Yep.
harbinger for long-term lung damage. It's it's it's
Mm.
it's easy to cause hyperexpansion
Yep.
and very hard to fix.
Yep.
And so thinking about that, we need to think about strategies that avoid
Hmm.
that.
Okay.
And one of the thing, again, I've taught volume targeted ventilation, but I would say in babies below 600 grams, we don't know what volume we should be using. Now,
Right.
we meaning folks who work with babies think in terms of 4 to 6 mLs per kg as almost a biblical tenet for the volume that we should be giving. We don't know that that's true on a 325 grammer. 325 grammer may have as much as 5 mLs per kg of dead space.
Yep.
So if you've got that much dead space, you're not going to be able to treat that kid with volume targeted ventilation. You're just
Yep.
not. So then you need to come up with strategies that avoid hyperexpansion if that's the enemy.
Yep.
And I do think that we have enough information to agree that that's the thing that we've got to avoid. And so I like early extubation strategies, getting to non-invasive earlier, high frequency strategies. I taught for Benell Incorporated. I love the oscillator. I think both the jet and the oscillator have a place.
Yep.
And so thinking about that, I used to say to clinicians, I don't care where you start, but I care where you finish. Recognize if your modality isn't working, be ready to
Hmm.
adapt. I also think it's incumbent, especially at larger NICUs. If you're a level 4 NICU, you need to have every tool at your disposal.
Agreed.
Uh, Something that drove me absolutely crazy a few years ago was listening to a physician give a lecture and say, the tool doesn't matter. The only thing that matters is your comfort with the tool that you've got. And
Mm.
I thought, I mean, I grew up in a farming community. That's the kind of
Yep.
thing you say if you've never actually been on a farm.
Right.
Because if you've got to do a specific task, you go get the tool that helps you do that task.
Absolutely.
Like putting in a Phillips head screw, I'm not going to go get a shovel. It doesn't care. And I don't care how skilled I am with the shovel. It's not the right
Yep.
tool. So you
Definitely.
need to have both the correct tool and the proficiency with that tool.
For sure.
And so I think that one of the issues that I've had in education, in teaching large level 3 and level 4 NICUs, is in a lot of cases, folks are one trick ponies.
Mm.
And it's okay if you've got an overarching theme or strategy. I actually think that's a good thing.
Yep.
Again, like I don't care if you're an early NAVA, early volume targeted ventilation, early jet, early outside. I don't care which group you're in.
Yep.
I wish people were better at recognizing when that strategy isn't working and adapting that strategy. You may
Yeah.
have a superlative BPD rate. You may be great at avoiding chronic lung disease.
Mhm.
But if that child in front of you has it, 100% of that kid got mistreated, or at
Yep.
least potentially mistreated.
Yep.
And so what could we have done from a process perspective to fix that? And to me, it's having all of the tools at your disposal and being proficient with them.
Absolutely. That way you have that other tool that you could utilize.
Yeah,
Kind of like you mentioned earlier, you adapt your strategy saying, okay, this approach isn't necessarily working. We have, B, C, and D over here. We're going to go with our B strategy next, utilize that tool we have. Because, yeah, you could be a great clinician, but without the right tools, you can't necessarily provide the level of care that's appropriate or needed for that patient. So,
right.
like you said, it's the tool and the clinician.
Yeah,
There's that synergy with right there that as clinicians, we have the right tools and we could provide our patient with the care that they need.
yeah, absolutely correct.
Yeah. Well, thank you for that. That's some great insight. Something, for me being in the kind of the more the adult world, I don't necessarily get that type of insight all the time. So I really appreciate that. Um, you know, just your insight from your years of experience and your
Yeah.
teaching background as well too. So, Brian, thank you for joining us today. Thank you for this fantastic insight and some knowledge sharing you provided today. We really appreciate you joining us today.
Hey, I really appreciate you. I thank you for this opportunity, and I look forward to more collaboration in the future.
Absolutely, for sure. We can guarantee that one there. So, on behalf of myself and Brian, we'd like to thank all the listeners for joining us today, and we'll see you at the next episode. Take care, everybody.
All right. Thanks, everybody.